Hello, everyone. It's 12 o'clock, so it is time for our routine What's New in Addiction talk. And today we have one of our addiction nurse practitioner fellows, Patty Wilson, who will be speaking on hepatitis C and the overlay with addiction care. Yeah, I'm really excited about this talk. I think she's done an excellent job, and I think this is an area of practice that we're only beginning to try and implement in a fulsome fashion to offer hepatitis C care and treatment for everyone who is eligible, and so I won't spoil it too much. I'm starting to talk about her talk before she does, so I'll save the spoilers and introduce Patty here. She's currently an addiction nurse practitioner fellow with the BCCSU in the current cohort. Her clinical experience includes working at the Calgary IO Clinic, as well as focusing on primary care in harm reduction, permanent supportive housing, and prenatal patients with opioid use disorder at the CUPS Medical Clinic in Calgary. Her clinical interests include primary care needs of those with substance use disorder, as well as harm reduction program implementation. She is the recipient of the 2020 Karna Award for Excellence in Clinical Practice for her trauma-informed care and teamwork working with clients who experience marginalization in Calgary. With that, I'll pass it over to Patty to share her presentation, and keep questions in mind. Hopefully we'll have a bit of time at the end. Over to you, Patty.
Great, thank you so much, Zach. So today for my presentation, I wanted to focus on how we can integrate the treatment for hepatitis C care into the care of people who use drugs. I'd like to start off by respectfully acknowledging that I am a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. Some disclosures to talk about. I have attended a sponsored dinner by Gilead that supported my own learning and becoming a prescriber of the treatment for hepatitis C. Gilead, the pharmaceutical company, it does make one of the pan-genotypic medications that are available. This presentation really isn't about specific hepatitis C treatment, and as much as possible, I will avoid naming any specific hepatitis C medications. However, the generic names for the hepatitis C medications are a mouthful, so if it does become necessary to name any of them, I will use the brand name, just because it will take me much longer to try and pronounce the generic name. So objectives for this presentation, I'm going to explore the prevalence of hepatitis C infection among people who use substances, review the evidence supporting the integration of hepatitis C treatment into the care of people who use substances, and outline resources for frontline staff and clients who would like to start testing and treating hepatitis C in their addiction setting. And this is an overview of the presentation. I should note that this presentation will focus on the non-incarcerated population of folks living with hepatitis C. A focus for treating hepatitis C within the prison system is its own special group and does deserve its own presentation. And also the majority of the setting I'm speaking to today will be an urban setting. So just an overview of the disease of hepatitis C. It's a bloodborne illness that affects primarily, although not exclusively, the liver. It causes the liver to develop fibrosis, which eventually can lead to cirrhosis and then eventually cancer or end-stage liver disease. However, the onset of these different phenomena is variable patient to patient. And there are extrahepatic manifestations that can occur as well, such as depression, diabetes, and renal disease. And in total, there are 6 genotypes. Not all hepatitis, when someone contracts hepatitis C, not all of it develops into chronic hepatitis C. However, the majority of cases do. There's a small percentage of people that do clear the virus on their own. globally, about 70 million people live with chronic hepatitis C, about 250,000 in Canada, and in British Columbia, about 60,000. The World Health Organization, they set out these targets with the goal to eliminate hepatitis B and C as public health threats. I'll be focusing on hepatitis C for this presentation. This was in response to scaled up testing, availability of harm reduction supplies, and coverage of DAA's direct acting antivirals, which is the treatment for hepatitis C. It makes these targets ambitious, however, feasible. So the goals, by 2030, globally, 90% of people living with hepatitis C know that they are living with that disease, so they have been tested and know their status. And by 2030, 80% of people who live with hepatitis C have started on treatment. I think it's worth spending a little bit of time understanding the cascade of care of people living with chronic hepatitis C, because it does sort of help understand the picture and the process that clients go through, and then it will help understand the evidence as well. So this is the typical care cascade for someone diagnosed with chronic hepatitis C and how they move through it, going from left to right. So starting on the left, we have the hep C antibody. This test is done via a point of care test or serology. The antibody test, if it comes back positive, it does not distinguish between current or past infections. And once someone clears the virus, either through their own immunity or through treatment, that antibody will continue to be positive, but it does not actually give them immunity from future infections. Next, moving across that care cascade, we have hepatitis C RNA, which is the actual viral RNA. If this tests positive, this does confirm a current active hepatitis infection. This can only be done via serology. And in BC, we have it set up that if someone has blood work drawn at a lab, so via serology, and the hepatitis C antibody is found to be positive, the lab should automatically perform the hepatitis C RNA, this is called reflexive testing, to determine if there is an active infection. If this is negative, then we can say this person, but the antibody is positive, then the person is hepatitis C negative, meaning they have either cleared the virus from their own immunity or through DAA treatment. And this is where we come to the first 2030 goal from the World Health Organization target. So by 2030, the goal is to have 90% of people with chronic hepatitis C know if they are hepatitis C positive or not. Next, we move into genotype. So there are a total of 6 genotypes of hepatitis C. Knowing the genotype has become less important recently because there are 2 hepatitis C treatments that treat all different types of genotypes, so they'll treat all 6. However, within BC, knowing the genotype is still a requirement on the special authority form. So it still is a requirement. However, there are 2 medications that will treat hepatitis C regardless of genotype. And this is done via a blood test. Next, we move on to treatment. Previously, treatment was only specialist-led. Now it can be prescribed by non-specialists. I'll describe treatment and what this involves a little bit later in the presentation. And this is our next goal from the World Health Organization. So by 2030, the goal is to have 80% of people with chronic hepatitis C initiated on treatment. And last in the care cascade, we have SVR. SVR is a sustained immunological response, what we could call cure. And it's worth understanding what it takes to get to SVR. So typical hepatitis C treatment in sort of an uncomplicated, very straightforward case, which is the majority of what I'm talking about today, is 8 to 12 weeks of treatment. So someone takes their medication for 8 to 12 weeks. For SVR, they have to have blood work done at the 12 weeks after their last day of medication. And then if that blood work at the end of that, so 12 weeks after their last pill, 12 weeks later, if that shows that they do not have hepatitis C RNA, then we consider that cured or they have shown sustained virological response. So if you, even though treatment is only 8 to 12 weeks, they have to they have to remain engaged in care actually for 6 months, which is a significant amount of time and real potential for loss to follow up when there's not sort of that ongoing care if we refer them out to a different clinic. You know, hopefully I'm going to convince you all to integrate it into your practice, and hopefully that loss to follow up for that last blood test will be reduced. So this is the care cascade within BC for hepatitis C. So I'm going to direct your attention to that first box on the left that's highlighted in red. So this is people with chronic hepatitis C and their knowing their status. So the World Health Organization, as a reminder, their goal for that was 80% of people by 2030 know their status. And so the very top, that dark blue, that is people who have never injected drugs, so people with no history of injection drug use. Currently, we're hitting about 73%, and then that medium blue, that's people with recent injection drug use, so that is 72%, and then the pale blue, that is people with past injection drug use. So if our goal is 90% by 2030, we're sort of on our way, but we still have quite a bit of ways to go to reach that 90%. If we were to move over to the next box that I've highlighted there, that is clients that have been treated. And if we look at the differences between the different groups that we have there, people who have never injected drugs, people with recent injection drug use, and people with past injection drug use, we really start to see the differences between the groups at that point. With people who have never injected drug use, 60% have been treated, but people with recent injection drug use, that drops down to 38%. And with past injection drug use, that is at 46%. And this is, again, as a reminder, the World Health Organization has set this target at 80%. Certainly at 60%, we're still nowhere near close to that target, but it drops even further for people who have that history of injection drug use. That is despite, if we were to even move over one more column to the SVR or the cure rate, those numbers are essentially the same across all three groups, but we're not initiating treatment in the same way. So we're not meeting these targets yet, and we're really failing our clients who inject drugs with treatment initiation, even though their SVR rates are essentially the same. And this highlights the real prejudice within our system. To highlight a few differences between treatment and why you might be hearing a little bit more about treatment for hepatitis C now compared to, say, 10 years ago. Prior to 2014, treatment for hepatitis C was interferon-based. The cure rates were very, very low. It was entirely specialist-led. The treatment durations were extremely long, months and months and months, and they're very complex drug regimens. So because of that, all of them required sobriety. So you couldn't have clients who were using substances engaged in treatment as a result of that. Even despite that, even if you had clients who were completely sober from all drugs and alcohol and were able to engage in the rigorous treatment protocols, the medications had substantial toxicities. And so even then it required discontinuation of treatment frequently because of the toxicities of the medications. Now, with direct-acting antivirals, the cure rates are extremely high. It can be prescribed by non-specialist MDs and NPs, so it can be done within the clinic, 8 to 12 weeks duration for most therapies, usually once-a-day dosing, and the side effects are very, very minimal. These are some common hepatitis C drugs available within Canada. So we can see most of them are once-a-day regimens. Some of them need to be taken with or without food. The last column sort of tells you the weeks of treatment. So we can see most are 8 to 12 weeks. And then most of them are one pill. There's one that's 3 pills all at once. So I wanted to also look at how important is this idea of adherence. Well, we continue to have clients who use substances that are criminalized. This can potentially impact adherence to medications because it introduces this this sort of chaos within their lives, will they continue to have to access criminalized substances. So this study investigated treatment adherence and associated factors among people with either recent IV drug use or current OAT, and it compared once a day or twice a day dosing of DAAs. It was a total of 190 participants. 97% completed treatment within this trial. It's a clinical trial. However, 40% were considered non-adherent. So this was defined as either as not taking their medication perfectly, either taking their medication late with the once a day dosing, or taking, for those who are on the twice a day dosing, taking only 50% of the medication for that day. The graphic that you're seeing there, it sort of shows the degree of adherence. The dark blue that you're seeing there indicating perfect adherence, so meaning the people on the once a day dosing took their medication at the exact perfect time, twice a day, they took both pills that day. The pale green indicating a missed dose, didn't take their medication at all that day. And then the teal at the bottom half of the graphic there indicating 50% of the dose was taken in the case of the twice a day dosing. So you have an idea of just how sort of infrequent, or you have an idea of that 40% adherence sort of in a picture there. Factors associated with non-adherence, recent injection of stimulants, homelessness, twice a day regimen, and generally adherence decreased over the course of treatment. Despite non-adherence rates of 40%, the SVR, so again, the cure rate in the once daily group was 94%, and the twice daily group was 91%. So still incredibly high. So this graph, this is again a clinical trial where they pooled data of interest, where they wanted to look at the safety of combining these medications with OAT. And to see if it led to any significant side effects. Again, thinking about the holdover from the interferon-based days and whether this would lead to dropout. So it's pooled data from patients with genotypes 1 through 6. They were treated with a pangenotypic regimen, so a medication that treats all 6 genotypes, in a phase 2 and phase 3 trial, and were categorized by use of OAT or controls that were not on OAT and did not identify as using drugs. So the clients on OAT were a total of 157, and then the controls were just over 2,000. Of the clients on OAT, 98% completed treatment and were considered adherent, and they achieved an SVR cure rate of 96%, and then they added up the adverse reactions that totaled over 10%, so what were considered significant adverse reactions, and those were headache, fatigue, and nausea, so relatively mild adverse reactions. So this demonstrates that DAAs are highly efficacious and well tolerated and safe medication for those who are on OAT. So this first graph was comparing pooled data, compared controls who reported no drug use and no OAT, and compared it to people on OAT. And we are looking at cure rate, or SVR, as an outcome, as well as treatment completion. Cure rate is essentially the same, with the control group achieving an SVR of 93%, and people on OAT achieving a cure rate, or SVR, of 90%. The treatment completion between these two groups, still looking on the graph on the left, is also similar, with 96% of controls completing treatment compared to 93% of those on OAT. If we look at the next graph over, this is actually comparing a similar phenomenon of interest. However, it's looking at people who inject drugs, so people who are not on treatment for their substance use, against controls for people who do not use substances at all. And the SVR among people who inject drugs was 88% compared to 92% of the controls. And 91% of people who inject drugs completed treatment compared to 95% of the controls. All right. This systematic review and meta-analysis looked at a similar trend, differentiating between those with recent injection drug use and those whose drug use and or past injection drug use and those on OAT. So there were no controls in this one. It just compared those three different groups. A total of 38 studies identified a total of 3,634 participants. In terms of treatment completion, there was no significant difference between the groups, and however, those on OAT were slightly more likely to achieve SVR or cure rate. So those were all based on clinical trials. I wanted to look at some real world BC examples as well. So this is Vancouver Infectious Disease Center. They did a retrospective analysis of clients enrolled at their clinic. 88% of their clients identified as people who inject drugs. They were able to identify 229 that were eligible to evaluate their SVR, so their cure rate when they took their data, and 90% of their clients had achieved SVR. The next one I was able to find is Victoria Kool-Aid. They did a retrospective analysis of 270 of their patients. To give you an idea of the complexity of their clients, 20% were co-infected with HIV, which in the treatment of hepatitis C, this does make the treatment regimen more complex. 46% of their clients were receiving OAT, and 49% reported recent IV drug use. 98% of their clients completed treatment, and there was no difference in SVR when they compared clients on OAT versus not on OAT, those with recent IV drug use versus not recent IV drug use, and those with HIV versus no co-infection with HIV. Sadly, 20 people did die during the study from street source drug poisoning, and this highlights the need to include harm reduction practices, including OAT, address social inequalities, and fight against bad drug policies as part of the ongoing care for this population. And then Vancouver Coastal Health is another example I was able to find. Another retrospective analysis of their 3 community health centers, Pender, Ravensong, and Downtown Community Health Center. A total of 138 participants, 52% on OAT, 3/4 reporting a history of IV drug use, 25% reporting injection within 1 month prior to treatment. 86% reported an SVR of, 86% were able to achieve SVR or cure. However, they had a significant dropout of people who were able to complete that end of treatment blood work. When we eliminated the people who were not able to complete the end of treatment blood work, because anyone who did not complete the end of treatment blood work was considered a treatment failure. So if we eliminated those people, the SVR jumped up to 95%. And those that were receiving OAT in the same clinic as the hepatitis C treatment were less likely to be lost to follow-up for that end of treatment blood work. Another concern that people have is the concern around reinfection for hepatitis C. So it's actually very low among people who inject drugs or on OAT. It's this one study found that recent IV drug use was associated with approximately 1.94 per 100 person years reinfection rate. And those on OAT, it actually drops to 0.55 per 100 person years. So it's a very, very low reinfection rate. Factors associated with reinfection include ongoing IV drug use, lack of confidence, which was an interesting point that was made. And unfortunately, this was not really further explored in that study, which would have been an interesting phenomenon to further explore. Homelessness, not surprisingly, and living with a person with hepatitis C. And this points to the need to treat cohorts of patients so that there isn't that reinfection. And really what this means is that reinfection is a very low risk among those with ongoing injection drug use, as well as those as OAT. Concern for reinfection should not be a reason not to offer hepatitis C treatment. Rather, concerns about reinfection should be a clue for healthcare workers to support for other areas in that client's life, such as addressing housing, treating those in their support circle, address substance use disorders and underlying reasons for those substance use disorders, and ensuring harm reduction supplies are accessible. There are also additional non-liver benefits. So these behavioral sort of changes that are listed here were based on questionnaires that were administered at baseline and repeated every 4 weeks during treatment, and then followed for a year after treatment completion. And it showed that there was a slight decrease in injection of opioids, a slight decrease in injection of equipment sharing compared to baseline. There was no increase in injection of stimulants or increase in non-injection routes of opioids or stimulants. So, excuse me. Additionally, no increase in alcohol consumption as well. Interestingly, I was able to find one 2020 American study that actually showed that co-locating hepatitis C and OAT actually increased retention in OAT. This was a retrospective observational case control, and what they did is their treatment arm received DAA therapy during the study period, and that was co-located within their OAT clinic. And this was compared to their control arm, which received care for OAT only. Treatment for hepatitis C and OAT was co-located. Baseline variables between the two groups were very similar, and patients in the treatment arm were 1.5 times more likely to remain engaged in OAT. Additionally, patients report feeling better. These positive outcomes were based on the 2020 European survey of patients that was completed across 7 countries. They preferentially selected clients who injected drugs to participate, and their survey demonstrates additional non-liver benefits to achieving SVR among those with hepatitis C. And hopefully I'm beginning to paint a picture for everyone that as a single intervention for a population that experiences stigma, marginalization, systemic violence, racism, and sexism, implementing a trauma-informed hepatitis C program within an addiction care model is one of the most trauma-informed programs that we can offer. It's also a really lovely experience for clinicians as well. A 2019 qualitative study from Australia interviewed GPs and addiction specialists on integrating hepatitis C treatment into their practice. Clinicians viewed initiating DAAs as an opportunity to strengthen their relationship with clients. Due to the simplicity of hepatitis C regimens and the prescribing and the monitoring, the high success rate, respondents found adapting the treatment very rewarding for patients and clinicians. Another Australian qualitative study found that clients felt they were seen as a more holistic person once hepatitis C care was integrated into existing OAT clinics. There were additional benefits for staff as it allowed them to see clients more holistically and not only as their OUD diagnosis. Overall, this led to greater satisfaction on the part of clients and staff. The quote there, nicest work I've ever done, it was from an Australian study. However, this is also echoed among local researchers. Dr. Sophia Bartlett, in personal correspondence, correctly highlighted that we rarely have the opportunity to cure chronic disease in healthcare, especially for those with substance use disorder. is no magic pill for HIV or trauma or substance use disorder. However, DAAs we can cure hepatitis C within a period of 8 to 12 weeks with minimal side effects, and it's incredibly rewarding to be able to share that experience with clients. I do want to highlight that a lot of the research that we're focusing on is integrating hepatitis C with OAT, and the focus is on those with opiate use disorder. However, we need to remember to also not forget about the care of those who use other substances as well, because they deserve treatment for their hepatitis C too. So why would we not also just refer out for this service? So that there's certainly an argument to be made that we could just refer out from our clinic to connect people with care. Even just exposure to OAT increases the likelihood that clients will access DAAs. There is a 1.5 increased likelihood that that exposure to OAT increases access to DAAs. However, those who experience barriers to healthcare do not need additional barriers like specialist appointments added to their care plan. And many addiction clinics are already structured to allow additional hepatitis C supports within their clinic. There was an Australian 2019 prospective observational cohort that followed clients at a primary healthcare setting. These clients experienced a high level of marginalization, including 77% homelessness. This clinic offered what they called enhanced supports during treatment, which was defined as either daily dispensing or weekly dispensing of medication. And of those that were able to complete the end of treatment blood work, they had an SVR of 96%. And the enhanced supports they offered very closely mimics what we already do with our Cadian and methadone dosing with the daily dispensing of medications. Additional supports for co-locating. Integrating hepatitis C into existing OAT clinics is feasible and acceptable. This is based on a 2019 Australian study that focused on not only staff perceptions, but clients. The concern at the outset of the study is that clients would, from a client perspective, is that clients would notice a change in the type of care they were getting because of the added burden of treating hepatitis C within the clinic. But this is actually found not to be the case. This also, treating hepatitis C care within addiction clinics, it decreases siloed care, and it decreases barriers for clients that already are required to navigate incredibly complex healthcare systems. They are less likely to be lost for that end of treatment blood work. Very importantly, it's not necessary to be stable on OAT before starting treatment for hepatitis C. This is a little bit of a holdover from the interferon days. And the support for this is a 2020 prospective open label trial at a harm reduction center in the United States. And they had clients who were diagnosed with OUD, opioid use disorder, as well as hepatitis C. Some of the clients who had opioid use disorder were already on OAT. The whole group was started on hepatitis C, and some were started on hepatitis C, and if they were not already on OAT, were started on OAT at the same time. Achievement of SVR was not associated with whether, so success with hepatitis C treatment or cure was not at all associated with whether they were already on OAT at baseline or not. So it's not necessary for someone to be stable on for someone to be stable in their substance use disorder before starting on hepatitis C treatment. Always important to consider the barriers when we're thinking about initiating DAAs on multiple different levels. So from a systems level, ongoing criminalization of certain substances, such as opioids or stimulants, compared to alcohol, cigarettes, caffeine, or cannabis, will continue to disproportionately marginalize some groups. This exposes these groups to increased risks of hepatitis C, interruptions to hepatitis C treatment, shame, and stigma. This creates a false narrative that encourages discrimination against these groups that translates into inequitable policies, attitudes, and care. Specific to hepatitis C, these groups include those who inject drugs and people, specific to hepatitis C and the presentation we're doing today, these groups include those who inject and use drugs and people with experience in the prison systems. Vancouver has voted to decriminalize drug use, but we have yet to see what this will look like. And there are concerns from advocates that this may lead to forced drug court and possibly seizure of personal drug supply by police. Other system level barriers include compartmentalization of healthcare services. On the clinic level, lack of on-site diagnostic testing. This can include blood work or fibroscans, a fibroscan being something that measures the fibrosis of the liver, which is needed as part of the hepatitis C workup. And then, of course, lack of funding. Depending on the funding model that you have for your clinicians, this can be a potential barrier as well. All right. On the clinician level, treatment of hepatitis C is not standard training and often needs to be sought out. A 2019 international cross-sectional study focused on physicians' self-reported perceptions and competencies related to testing, management, and treatment of hepatitis C. The majority of respondents reported low confidence and attended minimal training in the prior year. And competing priorities, we're working with a population living with multiple crises, overdoses, housing, and now COVID, and hepatitis C quickly falls to the bottom of that list. All right, and now some facilitators or factors that may help treatment initiation as well as completion. On the systems level, hepatitis C treatment for those on social assistance and Plan W are now fully funded. It does require special authority to get approval, but they are fully funded. Excuse me. Adequate housing was identified as a facilitator. This is not surprising. Homelessness was mentioned as a barrier to treatment completion and associated with reinfection in multiple studies. And it's not possible to have good health without adequate housing. On the clinic level, peer and outreach programs, people who inject drugs or people who use drugs have historically and currently a long period of time where a long period of trauma within the healthcare system, including the system that is set up to, treat their substance use disorder. And so there is understandably a lot of mistrust towards that healthcare system and towards healthcare providers. Engaging peers to help build that rapport and bridge that divide is invaluable. And outreach programs to meet clients where they're at is needed. This is also supported in the literature. A 2020 survey demonstrated that that the likelihood of those who are co-infected with hepatitis C and HIV are more likely to engage with healthcare if their network of people have a higher linkages of healthcare. Also, clinic level facilitators of integration of hepatitis C care into OAT clinics, which hopefully I'm convincing you of now. And then also nurse-led hepatitis C treatment and programs. I think sometimes as prescribers, we feel the need to be leading the charge with new programs. However, using a team-based approach, client progress, review patient teaching, complete follow-up appointments allows for offloading of multiple competing priorities, and it also shares the wealth of the benefits of the program as well. And then on the clinician level, generally clinicians do recognize that the hepatitis C treatment should be a priority and that it isn't important. We do want to offer good care to our clients. And then mentorship is very important, whether it's to discuss complicated cases or even just assistance with filling out complicated special authority forms. So now just to review some training and resources. So this is INSU. It's an international not-for-profit organization, International Network on Health and Hepatitis and Substance Users. It's a CME accredited program available. There are a series of online modules that are free, and when it's not COVID, it's followed by in-person workshops. They have excellent quick reference handouts for both clinical decision aids as well as summaries of existing evidence, and it includes access to foundational publications as well. There is an annual membership that is you can pay for, and it includes membership to a special interest group such as INSU Prisons. The Hepatitis C online course through University of Washington is a free online course. There's no in-person component. This is much more in-depth than the INSU, and it covers management of cirrhosis as well as special populations such as those with chronic kidney disease and HIV co-infection. This is the blueprint to inform hepatitis C elimination efforts in Canada. It was developed by the Canadian Network of hepatitis C experts. It focuses on priority populations, including people who inject drugs and people who use drugs, and it has Canadian-specific interventions, and its target audience is policymakers, program planners, and service providers. And it outlines a lot of the recommendations are also echoed from today's presentation. Other resources, CMAJ came out with a 2018 guideline on the treatment of hepatitis C, and Katie is a great website. It's targeted towards healthcare providers as well as peers, and it contains excellent harm reduction information handout, and it also has up-to-date Public Health Agency of Canada surveillance reports. Resources for clients. There is a Hep C care registry to help find a prescriber. There is assistance with system navigation, and then Katie as well. So in summary, we are not on track to reach the World Health Organization 2030 targets. In particular, we are failing people who use drugs and people who inject drugs. New DAAs are well tolerated and can be prescribed by non-specialists, MDs and NPs. DAAs have a high cure rate among people with ongoing injection drug use on OAT and are forgiving to less than perfect adherence. Additional non-liver benefits to DAA therapy are seen in both patients as well as clinicians, including increased retention in OAT. Co-locating DAA therapy and OAT increases Hep C treatment initiation and SVR. It is not necessary for clients to be stable on OAT before initiating DAA therapy. Ongoing barriers and facilitators should be considered when planning DAA programs, and Canadian-specific training for clinicians is available online. And some final take-home thoughts. Integrating treatment of hepatitis C care into addiction care is person-centered. Treating cohorts of patients leads to prevention of transmission among patients. And despite DAAs being technically universally accessible, clients continue to encounter many barriers to access. Our clients deserve good care that is tailored to their specific needs and that is reasonable to access. And here are my references. Oh, and that's everything.
Bravo.
Thanks.
Excellent, Patty. And it's always, anticlimactic after a presentation. You're used to the, we should have some canned applause after these, I think, just to keep us familiar with the process. So that was wonderful. So I'll open it up for any questions from those who took part. Of course, this is being recorded, and I know that format has been reasonably well adopted by folks that can't make it to these things. Really, it takes the pressure off having to come live if it doesn't work. But So, Adrina, I don't know if you've got anything question-wise. Just going to make sure I have all my right screens open for that purpose. Patty, what do you think is the kind of the dream format or clinic model to incorporate treatment? I'm thinking, busy flow of either a primary care clinic with a decent practice of folks that are receiving addiction treatment or OET, or a more specialized addiction clinic. What's your prescription from your review of the literature and just your own editorial on a clinic model and flow and team composition? How would folks fit this into their clinic life?
Do you mean like from a workload perspective, or?
Yeah, I mean, or how would they adjust their clinic model to be able to accommodate this?
Yeah, I'm a big fan of like pre-printed, just to make things because this is quite simple. Like I think it's very algorithmic, honestly, and identifying the cases that are not algorithmic that do require a little bit of extra time is not challenging either. So I think having like whatever term you want to call it, power plans, or so that if someone comes in and, I think a lot about like prenatal patients and how, you come in and that urine dip is positive and you decide to continue the pregnancy, and then like there is like, it is all just like a smooth oiled machine, and we know exactly what to do. We know the blood work to draw, and then we know, how to do things from there, and we just know how to do, and it's even simpler than that. It's even simpler than prenatal care. And so if we can do something like that, where we have pre-printed orders, and there are certainly complications that come up in prenatal care that we can kind of flag and say, like, oh, okay, this person has a decompensated cirrhosis, so this might not be appropriate to treat in clinic. We need to flag this and help facilitate a specialist appointment, or when the visiting specialist comes here, we need to get this person high on the priority list, and how can we help facilitate them coming to the clinic that day? There are always going to be those special cases, but to me, if we can do prenatal care, this is not that big of a deal. Or if we can initiate somebody on like a Suboxone microinduction in your clinic, because we just have our like, okay, well, they did their urine drug screen, and then we saw that, we saw all of these things, and we have our pre-printed Suboxone microinduction, and we know that in a week we're going to see them again. It's just of just writing out that process, and it really is that simple. It's a little bit of, I think that's where the mentorship comes in, is learning how somebody else did it, and then not reinventing the wheel and just plunking it into your clinic and figuring out what works in your clinic.
Excellent. No, that's great analysis, and yeah, I think you're right. It's like any new practice or any previously highly complex and variable, specialty intervention that becomes simpler with newer treatments, or just simply a better understanding of the safety profile. It's just a matter of changing the culture and readiness to incorporate. I'm thinking of transgender medicine and transgender care, trans care in primary care. There was, pushback, or maybe not pushback, but lack of readiness to incorporate, just with a presumption that it was incredibly complicated and hard to really grasp, when really, diabetes is probably as complicated or more complicated in the management of it as opposed to aspects of trans care. So I think that's part of the evolution. Okay, I'll ask a question from here on the post board here. So great presentation. Did you see stats or recommendations on hepatitis C treatment in the context of alcohol use disorder?
No, I didn't. It's the focus is mainly when I looked into addictions. The focus I found was mainly around opioids, and I think probably the bias with that is because methadone and Cadian are once a day dosing. So when we look at adherence, it's just so easy to roll those together and have your DAAs dosed once a day along with your Cadian or methadone. To my knowledge, there's no contraindications to that. Where it gets a little bit sticky, or not sticky, I shouldn't say that, where you start to maybe want to consult with a specialist is in the context of sort of cirrhosis or advanced or decompensated cirrhosis. And that training sort of, if you go through INSU or the University of Washington course, it does speak to that a bit more specifically. But there's no like alcohol intake on its own is not a reason to not treat hepatitis C.
Right.
If anything, actually, I should say a bit more further on that. If anything, that's a reason to treat it even more, because having hepatitis C and having alcohol use disorder coexisting, it exponentially worsens liver failure. And that's actually, if I can share a personal story, it's the reason I became interested in treating hepatitis C, because I had a patient who died quite young in his early 50s. And he was in one of those permanent supportive housing buildings. And, you know, he would come to me and I watched him go through like liver failure in front of my eyes. And he had such trauma with the healthcare system that he would really just come see me and that was it. So I watched him do it right in front of my eyes and wouldn't seek outside healthcare at all. And I just thought, like, if I had just treated, like, you know, the alcohol use disorder, it's tough, right? Like alcohol use disorder, it's a really tough one, but I thought I could have done his hepatitis C. Like I could have treated that and maybe prolonged his life, right? And I could have given him years, but I didn't know how to do it. And so after that, I thought, oh, I can do better than this. Like I can learn from that. And that's what pushed me to want to try to do this.
That's great. I think you're right. Really, the the return on investment or the absolute patient risk reduction with coexisting alcohol use disorder and HCV is there's even a better argument in favor of aggressive treatment and intervention. So yeah, but definitely that piece around a captive audience and adherence to the regime with the daily dispensing is probably a key part of the success of those studies with co-treatment with OAT. And the carrot of daily dispense acamprosate or something like gabapentin is compelling. I'll give one last chance for any further questions. And if nothing more, then yeah, Patty, if do you want to share your email if folks have any further inquiry or questions around this?
Yeah, sure. I don't know. How do I put that into the chat?
You can type it in, and you can also just say it. I think for people that are listening.
I don't know if did that go anywhere? I put it somewhere.
Yeah, it went in, and oh, I got another question as well. So we'll use that with our remaining few minutes here.
Okay.
Excellent presentation, great overview. Relatedly, how do you see the role of hospitals and acute care services in facilitating access to hepatitis C treatment?
Yeah, we don't do great discharge planning as is. So like we can barely facilitate an OAT script. So I wouldn't I wouldn't say we want to start initiating DAAs quite yet. I think that, so I wouldn't say DAA prescriptions quite yet, but certainly there is a potential to, when someone is admitted, to do that baseline testing. So even just checking, like, well, when was their last antibody test? Oh, their antibody test was positive. Well, have they had the RNA test? Oh, they have had the RNA test. Well, have they had the genotype? So at least starting them down that track, because sometimes clients, you know, you might, depending on how busy your practice is, or if you sort of operate in a model within your practice where you have like a visiting specialist, if you haven't quite gotten Hep C totally integrated in your care and you have a visiting specialist once every 3 months, having all of the blood work completed, so that when that person shows up and it happens to be a day when a visiting specialist is there and oh my gosh, there's a no-show, and the hospital, thank goodness for them, they completed all of the blood work while they were an inpatient, is hugely helpful. Like that is just golden. I mean, I would love for it to be something like, oh yes, they, you know, while they're an inpatient, they started them on, you know, methadone, and also they started them on a DAA, and they can continue this in the community. But I think I've seen how rocky those discharges can be. You know, one day, I don't think we're quite there yet, but that would be lovely at one point. I think another really big thing would be that understanding the importance of when you have a client come into hospital and you see on their PharmaNet, oh yes, they're on DAAs, make sure that continues. That would be another really important piece, that you have the potential to continue that in hospital. And as much as we say, we don't need perfect adherence, and you don't, who knows what their life is like outside the hospital. If they're, you know, people struggle to take a pill every day as is. And if while they're in hospital, you can help them, assist them, and they can have perfect adherence, like all the more likely they are to clear that virus because of their time in hospital and that perfect adherence. So like help them out with that for sure. Don't start home meds 3 days into their hospital stay. Start it as soon as you can. And usually you can do that by contacting their home pharmacy. And I'm from Alberta, I'm not from BC, so I don't know if this is realistic or not. In Alberta, what we've done is we've just contacted their pharmacy where they got their DAAs delivered. And then usually we would just like, talk to that pharmacy and figure things out to get a delivery there from their home pharmacy to the hospital.
Excellent. I think those are good points and analysis. Great. So just looking for any last stragglers with questions. Nothing. So that's great. So let's close out. So thank you very much, Patty. I think this is an important area and something that we'll see growth in the months and years to come. And anyone who is passionate about this area and has further questions for Patty, please contact her. And with that, we'll close out. Thanks everyone for your time, and have a good rest of your day.
Great, thank you.